Hello, my name is Vanessa Damani. I'm a second year medical student at MBRU, and in this video I will be walking through a chest x-ray interpretation as I would during an OSCE examination. Starting with the 5 W's, this is a PA chest radiograph of a 20-year-old female Vanessa performed on the 8th of June 2026 at 10 p.m. in a health clearance center as part of routine screening. Now, moving on to assess the quality of the chest radiograph. Starting with rotation, the medial end of the left clavicle appears slightly further from the spinous processes compared to the right, suggesting mild rotation to the left. Assessing inspiration, approximately 9 posterior ribs are visible above the diaphragm, indicating adequate inspiratory effort. In terms of picture, the radiograph includes the thoracic inlet down to the diaphragm and extends laterally from skin to skin, so the image is well centered. Finally, regarding exposure, the image appears slightly overexposed as lung markings are clearly visible, but the thoracic vertebral bodies behind the heart are not well visualized. Before I move on to my ABCDEs, I'd like to make sure I'm doing no harm and check if all the tubes are placed in their correct positions. In this chest radiograph, I don't see any lines or tubes, but generally I'd assess if the endotracheal tube tip is 2 ribs above the carina and the nasogastric tube tip is 4 ribs below the diaphragm. Now moving on to my ABCDEs. A, which stands for airway. The trachea appears to be in the midline at the level of the clavicles. The carina is not splayed and maintains its normal approximate 60-degree angle. The right and left main bronchi appear patent with no obvious obstruction. B, which stands for breathing. Comparing both lungs from apex to base and side to side, the lung fields appear clear with no focal consolidations or obvious opacities. Pleural spaces are free and normally not visible. In case of a pneumothorax, you'd see air, which is lucency between the two layers of the pleura, the parietal and the visceral. And in case of a pleural effusion, you'd see blunting of the costophrenic angles. C, which stands for cardiac. There is no evidence of silhouetting of the cardiac borders. The cardiothoracic ratio is less than 50%, therefore there is no cardiomegaly. D, which stands for diaphragm. The costophrenic angles are sharp. The right hemidiaphragm is slightly higher than the left, which is a normal finding due to the liver. A small gastric bubble is visible beneath the left hemidiaphragm. E, which stands for extrapulmonary findings. There are no obvious bony fractures or lesions on this view, although I would ask for another view while assessing the bones. The soft tissue appears unremarkable and no foreign bodies or devices are seen. To conclude, this is a normal chest radiograph. Thank you so much for your attention, and I hope that this was helpful. Remember to approach any chest x-ray systematically, starting with your 5 W's, your right, lines, and then your ABCDEs. Focus on describing what you see rather than trying to make a diagnosis, and report your findings and reasonings out loud so that the examiner can follow your thought process. Thank you so much once again.